Dr. Alvarez, for those of you who don't know me. I'm here to talk a little bit about Central Line today. We are going to start doing more kind of at the bedside in terms of Central Line placements. So I kind of want to go over steps, setup, indications, complications, etc. When we need them, why we need them, and how we can use your help specifically. So most of the time, central lines are indicated for vasoactive substances, so pressors, they're needed for transfusions, anything you're going to get fast through a big, large bore IV. They come in different sizes, so here we have a 20 centimeter, usually meant for left-sided central line placements. They also come in 16 centimeters, meant for right-sided placements. For the most part, we use 20s because these kits actually have the sterile saline. They also have caps, gowns, and a mask as well. When you put a 20 in, one thing to remember is that we also kind of pull back a little bit. So if you see a central line and you see us kind of half the wires out, it's because we don't want to go into the right ventricle. We want to pull it back and make sure that we're tip of the catheter is right at the right atrial junction with the SVC. So that's why the 20s always have are a little bit more pulled back than the 16s that are flush. In terms of preparation, so most patients that we want to do this for, they're pretty sick or they're intubated, but we got to really talk to them, explain to them what's going on. From your end, it would be helpful, let them know, hey, the doctor's going to put in a big IV in the neck. We need it for X, Y, and Z. Kind of explain to them, the procedure, what it's going to entail, and what we need from the patient. Specifically from them, we need them to stay still if they're not intubated and not be moving, especially when we're putting or advancing the needle on the wire. The patient also would need to be told that they're going to be in a little bit of reverse trendelenburg position to help with expand the IVC, the internal jugular vein, and get better access as well. So they'll be a little tilted back, let them know that as well, so they know that. They're also going to experience some cold from the ultrasound and the numbing needle from the lidocaine. Can be painful because sometimes when you're numbing the IJ area, you don't get all the way down into the vein, you get right above the vein. So you try to numb with lidocaine all around the area that you're going to stick, but not to go into. You don't want to inject lidocaine into the vein. If you do that, it can cause an arrhythmia as well. So that's kind of preparation for the patient, letting you know and expectations what to expect during the procedure as well. In terms of setup from your end, what we would like is if we can get all the wires sort of out of the way, especially if we know what site we're doing, if we communicate and say, hey, I'm going to try right IJ. The right IJ is our preferred site versus the left IJ. It's just an easier course straight into the right side of the heart. It doesn't have to kind of come across. It's easier line placement. The femoral sites are kind of a second choice and less preferred. You can also access the vascular system to the subclavian site, which is not routinely used here, primarily due to risk of complications in terms of pneumothoraces. And it's a blinded line, it's not ultrasound guided, which we prefer as well. So in terms of setup, so like I said, we're gonna do right IJ. We'll try to get kind of all the wiring out of the way. Sometimes you come in and do a line and there's oxygen tubings here. We have the EKG leads coming out this way. And it's really in the way of the field. So we wanna prep a nice sterile site, a nice sterile field for the central line placement. So if you can move the wires, either get them to the left side of the bed or get them down, moving towards the feet, and then kind of run back up underneath the bed to have that, make sure that their leads stay on during the procedure and that their O2 set monitor stays on during the procedure as well. So from that aspect, getting that part ready for the wires, and then when we're ready to start, we'll get in the room, we'll do a timeout, we'll do site. We always got to do a timeout, even if it's an emergency situation, time it out. Make sure you document in the computer what we're doing, that we have consent. If we don't have consent, it may have to be emergent consent due to whatever situation is going on with the patient. And if the consent signed by family, that's stated as well. We'll go over site, what we're doing central line, right IJ, this is the patient, this is the fin, etc., and time it out appropriately. From there, we go on to preparation. So part of the preparation is we're gonna sterilize the area. This kit, and we'll open it up, has chlorhexidine. So, and prior to this, usually what I do, and some docs do it and some docs don't, sometimes IV team helps, we look at the site first. So before sterilizing, we'll get the ultrasound probe and we'll look and see you know, if we have a good access point. Some patients have really small internal jugular veins. Some patients have collapsed or obliterated internal jugular veins due to multiple different accesses, especially the renal patients that have multiple access catheters placed. You go in there, you can't really even see an IJ, it's just a carotid artery. The internal jugular lies anterior and lateral to the carotid artery, so if you see just, you know, just a carotid and an obliterated IJ, I've seen it before, patients are a big clot in there, and then you can't run a wire. So I usually scout out the area. Some docs don't, sometimes just prep, and if you don't have time, you just kind of prep and look and see and try to find the IJ like that. So these kits are actually pretty nice. So they come in a sterile package. And what I usually like to have is a table at bedside like this, and use the table as my sterile field. So as you open it up, you see that there's a mask already here and a hat. So it's how you don't have to gather that if it's in one of these kits for us. These kits have a hat and a mask, and they also actually have a gown in it as well, so you don't even need a gown. So the kits have pretty complete. So if you're in the room with me or whoever's doing the line while we're prepping, everybody needs to have a mask and a hat on while we're prepping, and that's part of sterilization procedure. So if you're going to be in the room, mask and hat. Even if you're not going to assist with the procedure, you don't have to be completely sterile, you don't have to get a gown or gloves on, but just a hat and a mask. So we'll put our hat on, we'll put our mask on, and then we'll put our gown on. We would need help putting on the gown, and I'll show you that in a second. But prior to doing any of that, there is a chlorhexidine prep in here, and if possible, if we're getting the patient prepped for the line, and what I was asking Lexi to do is, if you all can help, if we get the patient, you know, set up right, wires out of the way, get their neck turned to the left, and then if we can prep their neck and drape them, that'd be a huge sort of time-saving step for us. Knowing that we got the consent, we got everything, we know we're going in the right IJ, and then that's the point where you put on your mask, you put on your hat, you turn the patient, turn their head to the left a little bit, and then we start prepping the site. So you'll prep all the way from the jawline, all the way to the chest, all down the neck to the back posterior. So this whole area gets prepped. The whole right side of the neck gets prepped. Again, you have your mask and your hat on. Once they're prepped, there is here, and we can probably get a kit that has a separate dressing kit on there. But these actually have instructions. It tells you how to put them. So arrows head up, and it has a little guy up here that tells you which way the head is up, so this way. So when you peel the wrapping off, or the sticky, head this way, you'll put it like this, and then you'll fold it out, arrow out, arrow out, arrow back. So it has instructions on where to, you know, how to do it. And then this is a nice one because it goes all the way down to the feet of the bed. And then it has a sterile cover over the site field. So if that's what you guys can do for us, that'd be fantastic, because the next step for us involve ultrasound setup, which we'll go over, lidocaine, and the kit setup as well. But this step in terms of moving the wires, getting the patient set up in the bed, getting everything out of the way, getting the site prepped, and putting on the sterile gown or drape over the patient would be a great step, yes.
I hate to ask a question, but you want us to sterilize, open the kit and do all this?
No, that's what I'm saying. We probably would need a separate kit, because the kit has all the stuff inside of it, a sterile drape.
Okay.
But yes, ideally would be great and time saving. If IV team isn't available to help us set up.
It would have to be sort of soon, because then that patient has to lay there and not move.
Well, that's what I'm saying.
Yeah.
It'll be like, hey, we're ready to go. Can you set up, you know, ideally would be in a room doing something else or seeing another patient, and I'll ask you, can you help set up the patient up for the central line, you know, prep the site, put the drape over the patient, and get ready to go. And yeah, I mean, that's why it's part of sort of educating the patient what to expect before the central line, like you're gonna be laying flat, you're gonna have a gown over your face or a drape over your face. Most of these patients are intubated already, so they don't really kind of participate in that, but educating them and letting them know kind of what to expect. Usually if they're awake, I'll talk to them while I'm doing it. You're gonna feel a pinch, you're gonna feel this, you're gonna feel that, you're gonna feel a cold solution, you're gonna feel the ultrasound coming through, etc. But ideally, yes, it would be helpful. We're not gonna get a lot of assistance from the IV team to help set up in order to help time save for us. If we can, site prep would be at least a time saving step for us.
And I think too, so it'll depend on the patient itself. Like if the patient, let's say, is on prop and fent and they are thrashing and everything, obviously your more important thing is gonna be getting the supplies in here, getting the patient adequately sedated before you're starting to do it. Because yeah, you don't wanna go through all of it and then waste, because the sterile field gets broken when the patient's thrashing. So I think
I don't want
that's
anybody
important.
kicking or screaming. They gotta be
Yeah.
calm, and before sterilizing, before draping them, they gotta be calm and kind of ready to go for the procedure. It's not gonna be like, there's some patients where, it's a battle to try to get a line in because they're, not sedated or agitated, and it's not a safe place. You don't want somebody moving or thrashing with placement of a central line, because you can get complications like pneumothorax, you can have the wire run the wrong way, you can get air embolisms, all kind of stuff. So you want the patient as calm as possible before doing this. And most patients are, or they're sedated, and we can give them medication. If you try to explain to the patient that this is what they need to have done and they're not adequately calm, we can give them medication to sedate them for the procedure, so they can tolerate it and be calm during the case, because that's the biggest thing, is them being still, especially when you're accessing the site.
Can I ask one more thing too, Dr. Alvarez?
Yeah.
If the patient's not intubated, did we talk about the patient wearing a mask?
Patient doesn't have to wear a mask.
They don't have to wear masks as long as their face is covered with a drape.
Correct.
Okay, and the scrubbing, at least 30 seconds? You have
30
anything
seconds and prepping the big site area, which is the bigger area that we think is not just right in the neck, it's
All the way through.
jawline,
Okay.
all the way through down, and then to the back.
Got it.
But yeah, they don't have to wear a mask if they're underneath the sterile field. So after this is set up, we'll come in to the room. These kits are pretty good. Like I said, they have already sterile saline in them, so you don't have to have any saline into the room. The only thing these kits were missing before were the covers or the caps, but actually they include them now as well. The kits also have an ultrasound probe cover already in them as well, which is new on these kits as well. Inside the kit, you also find the covering for the central line, along with lidocaine for numbing, a lidocaine needle, and then, so lidocaine needle, lidocaine administration needle, and then the central line access point. There's 2 needles in here for central line access. There's an 18 gauge, which is this one, which has a hole where the wire goes through. And there's another needle we call the angiocath needle that is almost like an IV, where it has a catheter over the tip, where you puncture and then slide the catheter in. And we use those in certain situations where it's difficult to maintain access, or you keep losing your access once you get a flash into the patient. So when we walk in, we'll put on our masks, hats, gown, gloves, and then we'll have access to the kit. The first thing that I would do is really grab the ultrasound probe cover. So I'll grab the ultrasound probe cover and then ask for assistance in terms of putting that on. So every kind of probe cover is different, but most of them, they have gel in them already in the kit. And I'll put about half the gel into the probe cover, and I'll leave half the gel for the site. And just like Chuck's doing, you hand it to me like this, and then we'll just run the cover over it so that it's outside of the sterile field. And then they usually have rubber bands in these kits that you put around the probe to secure them in place. So once my ultrasound is set up, then I turn to my kit. what we like to do is, I like to always flush my line to make sure that the central line actually works and there's no holes in them. I have found defective central lines where there's side ports that don't work. Prior to insertion, it's always good to know. So I usually flush all my ports. So flush all the ports one by one. And you can, what I do is I usually attach, if I have the actual caps that are gonna go out, so that's coming out of the side port there. So each port comes out of a different hole. So flushing all the ports, make sure they work. And I go ahead and put on the sterile caps in the blue and the white one, because your wire is always gonna come out of the brown port. So I can go ahead and cap the blue and the white, wire always comes out of the brown port. Once I know my catheter is working and functioning, I go ahead and open the lidocaine kit. And I'll draw my lidocaine from in here. I'll grab the ultrasound and assess my site. And I'll look to see what is a good access point for the patient. I want to stay above the clavicle. And again, usually you can find the artery pretty easily, and I'll kind of show you on the patient afterwards or on one point of view. And what I look for is make sure that the vein is compressible. Always the artery is not, like when you're putting an IV in. And sometimes what happens is although it's supposed to be anterior and lateral to the carotid, sometimes the vein is right over the carotid. So some complications that can happen is that you kind of go through and through, where you access the vein, push the needle right into the carotid, and you can run the wire into the carotid. So that is a possibility as well. So a misplacement of a central line from that, where you get access and you see venous blood, mistakenly you advance the needle, you run your wire, and unknowns to you, you're advancing it into the carotid. So it's always important. What I do always is, once I have access into the vein, I run the wire, and I always check with my ultrasound to make sure that my wire is actually in the vein and not in the carotid prior to dilating. Because if you select the carotid and you run a wire, you're okay, as long as you don't dilate it. If you dilate it with a dilator, now you're in a little bit bigger trouble. Okay, so I got my lidocaine, I look at my spot, I found a good spot, I numb the area, and then I'm kind of ready to go. So I drop the lidocaine. Things I need, so I need my wire, because this is Seldinger technique, and Seldinger technique is running a wire over a wire through a needle and then dilating it up to put it in the catheter. So these wires are J-tip wires. You always want to run the wire with a J-tip towards the patient or into the patient, and with the hook towards the heart. So if you're putting in a right internal jugular, you want to make sure that that hook is facing the heart, which is on the left side of your chest. If you're running it on the left side, you want to make sure that that hook is facing the right side, meaning because you want the wire to travel to the heart this way, okay? You don't want to run the wire with the hook facing laterally on a patient, because you may get into the subclavian and do a reverse central line, which is another complication of a misplacement, where you look at the x-ray and the line goes like this. Sometimes if you get resistance, the wire can bend on itself, and you can end up with a line placement like this, which is a line going up into the skull, or up the internal jugular vein into the head. Sometimes from the left side you can get a misplacement here as well, and it can get stuck. And you can run into the subclavian here as well if you're running the hook to the left side. So I've seen all that happen before with central line placements. So what I generally do is I make sure my hook is facing the right way. So the hook on the line and the band is facing to the left. It's for a right internal jugular placement. I pull it back to make sure the tip is in. I set it aside. I also need my dilator. So I'll grab my dilator, set it aside. I'll grab the line, put it in an accessible point, and then I use the scalpel to make a small incision for accommodation of the dilator. Okay. So once I have all that, I feel like I'm ready. Nothing else in the kit that I need right now. So I look with my ultrasound, and I use the blue syringe usually. If it's a nice vessel. Again, this is an 18 gauge syringe. Once I see a good point, under ultrasound guidance, I'm looking at my ultrasound. I see it wire where I see the needle where it is. I advance, and I'm usually pulling back suction on this. And usually you have to go into the vein, through it, and then come back into the vein to get a flash. Because the vein, when you're pushing down, you usually compress the vein, so it'll be collapsed, and you're not getting any kind of blood or venous return. And once you pull up on the vein, it'll expand, and then you get your flash. Okay. So I go through the vein, come up into it, I get a nice return. This, you can do two things. You can unscrew it and run your wire through this needle like this. So advancing the wire. Or in this particular case, this needle has a hole on top, which makes it nice. You can hold it in place and run your wire from back here. So you run your wire all the way. When you're running your wire, what some of you have seen and can see is you can get ventricular arrhythmias, because now I'm advancing the wire into the right ventricle, which can cause arrhythmias. So sometimes you see VTAC. You see that, alert the doctor. We'll pull back on the wire a bit until the VTAC stops. But at least it helps us notify us that we're in the right place. You pull out the syringe and the needle, leave the wire in place. Once that's in place, then you make a small nick at the entry site of the skin. A small nick to allow for the dilator to advance. You advance your dilator into the internal jugular vein. And this is after confirming with ultrasound that you're in the right place. So I always like to confirm again with ultrasound that my wire is actually in a vein. Compressible, and usually if you hold it parallel to the wire, you can see the length of the wire inside the internal jugular vein. So you go ahead and dilate. When you dilate a vein and you pull back, it's usually where you're going to see a lot of blood. So because you made a bigger hole than your needle stick was, and the patient will bleed. Some complications that can happen at that point, this happened to me, is if you get scared there's too much blood coming out, sometimes you'll pinch the wire. So you'll press down to stop the bleeding, and you'll make a nick or a kink in the wire. And then when you go run your catheter, you have a hard time advancing because these wires, they kink very easily. This happens a lot in the groin sometimes when you're running a wire in and you want to hold blood because you dilate and there's a lot of blood coming out from the femoral. And then that's a problem because then you can't get your wire out. You can run the wire and then the wire gets stuck and the catheter gets stuck. So we've got to be real careful that we don't hold too much pressure. It's okay to have a little bit of blood loss during the time. You make sure that you're able to dilate, hold the wire, and then you advance your line. Like I said, you'll see that the line is going to come out through the brown port. So once I get the tip of my line in my hand, I usually advance the catheter and pull out my wire, okay? So big steps here, what I do next is I want to make sure that all the catheters are working properly. Sorry, all the ports are working properly. So I flush, again, all my ports, and I also draw back to make sure that I'm in the right place. So what's happened sometimes is there's either a kink in the line, or if you're misplaced sometimes, like one time we've placed in the subclavian, so you're like this, and maybe you can draw back from your distal port, but your side ports don't draw back, or they don't flush very well. You know right there that there's a problem already with the line. And if we finish a line and you start drawing back or flushing, and you're like, hey doc, this port's not flushing right, or this port's not drawing back right, there could be a problem with the line placement. So you gotta make sure you get an x-ray, make sure it's in the right place. Sometimes the ports do go bad if they're been in there for a while and they get clots on them. They can get clots from having these catheters placed for a long time. It is a vein, and the ports can clot, and then one of the ports stops working, so you have to use the other ports. But if it's an immediate placement and you're getting trouble with drawing back, it's in the wrong place. It's a misplaced line likely, and it has to be readjusted. Sometimes pulling back helps, but usually if it's going this way or going back, you gotta pull it out, stick, and do a new one as well. So I put all my caps on, I make sure all my lines flush and they draw back appropriately. And then, so this is a 20 centimeter. Again, we wanna pull back. I usually, the space that these little caps provide, that you'll see, there's a little butterfly, white and blue. The reason that's there is for the 20 centimeter lines to pull back on the right side of lines. You don't wanna be in the ventricle, you wanna be at the junction of the SVC and the atrium. So usually it's about 4 centimeters you pull back. So you may have about this much hanging out. And then I suture here at the caps, and I'll suture the head of the line too. Sometimes the line team has the clips that they use for the pick team, which is like it's a plastic clip that goes on that can be put on the head of the line as well, which helps avoid suturing that. So you can suture these two and then put the clip on the head of the line as well. And then we put our bio patch, which should be in here as well. We put our bio patch on, and we put our dressing on. And then, you know, that's it from our end. We usually just hold that down, take the sterile prep off, and the line is in place. So again, the biggest complications that we can run into with the central lines are pneumothorax, especially if I start poking down when I'm trying to get access. If I'm poking down and I'm having trouble, and you see me doing multiple sticks, and I can't get access, I'll start going down the vein closer to the clavicle, okay, where the SVC and the IJ meet. In fact, IR actually likes to go right at that pocket where the SVC and the IJ meet, because sometimes you have a lot of strictures in the internal jugular and you can't advance the wire. So they sometimes stick there, but the closer you are going to the clavicle, the more chance you have of getting a pneumothorax, because that needle moves a little bit and you advance right into the apex of the lung and you can collapse the lung. If you see me sticking high up here, and we were always taught to go as high as possible to avoid anything in the lung, and that's fine. Sometimes you see lines all the way up here, sometimes you see lines up here. Anywhere in this area is fine. What I call the pocket shot line, which it drops right at the SVC and the IJ junction. You do those for ones that you can't really run the wire to, where I got access up here and I tried to run the wire and I'm getting a lot of resistance. Another adjunct that we have for that problem, if you see me trying to get a line and I can't run a wire, is IR has these nice micropuncture kits. And these micropuncture kits, are they here?
Yeah.
Yeah. The micropuncture kits have a small, really, really thin wire. I believe the needle is a 22. And this allows you to run a very, very thin wire. It's actually a 21 gauge needle. Allows you to run a very, really thin wire past a lot of those strictures. And then you just do serial dilation. So you run the thin wire down, you run this little dilator through it, and then you can run your bigger wire through it and then serially dilate from there. So that always helps sometimes when we're having trouble getting access or running a wire down. So some troubleshooting that you may ask us to do is, hey, I'm having trouble running the wire, I'm getting stuck. Can you get me a micropuncture kit? And these are the kits. We put them in the cart now. And I'll ask you to bring me a micropuncture kit. And the reason why is I'm gonna see if I could stick a little bit lower and also serial dilate to get better access for the patient. You usually use these in the patients that have multiple venous accesses, like the hemodialysis patients that had a lot of strictures already developed over time as well. So complications, like I said, pneumothorax, difficulty running the wire, line misplacement, air embolism, usually they're put back. Try to avoid that whenever you're flushing the central lines or putting in, make sure that all the air is out of the line before advancing forward. So those are kind of the major complications. So bleeding risk or hitting the carotid can happen as well. So let's say line misplacement, you went into the carotid. For the most part, you know, notify the physician if you're getting bright red blood back and if it looks arterial. And then we'll check to see if the line is misplaced. But those lines can be pulled out usually with pressure. It'll be okay. Sometimes to kind of be safe, you'll ask vascular surgery on their advice, let them know, hey, there's a line misplacement, what should we do? If it's an HC catheter that's misplaced, maybe even in the OR, it should be removed with pressure. So Never just pull out a line that's in the carotid. Make sure you have the physician do that at their discretion. That's not something that you'll want to do. What else? Questions that you want me to cover, topics?
I wanted to mention, you guys, we got a couple trialysis catheters that are gonna link now in a Central Line kit. And this actual kit doesn't really have anything in it, it's just the line. So most docs are gonna need your full Central Line kit even for trialysis. Trialysis is just a difference in line, the actual setup and insertion is similar, very much the same.
It's actually exactly the same. The only difference is that the dilators that we have inside the HD kits are much bigger. So this is the dilator that we have for the Central Line, which is 7 French, and I believe those dilators are much larger. Yes.
So would you ever do an exchange? Say they already have an IJ and we need dialysis stat. Okay, so we would give you this exchange and you would come and do all this stuff.
Yeah, I mean that's a bit more of a complex setup, but yes. So usually, what that involves is having a bunch of sterile towels and sterile solution. And what I usually do is prep everything in the neck, including the line that's in there now, and I'll wrap the line in sterile solution soaked towels to protect the line on my sterile field. And then you advance the wire through the line, you pull out the wire, you dilate with the HD catheters, and you can go ahead and put that Central Line in. So that's a different setup, but for exchange, usually it's a bunch of sterile towels, sterile solution, to let that line stay on your field.
So would you mostly, say it's the weekend, you know, and calling a team in from IR is one thing, but you would be doing, or someone would be doing something like this?
Yes,
An
for
event.
exchange, yeah. But yeah, that's sort of the setup for a line exchange. I don't like exchanging left-sided lines. It just sometimes it's a problem with an advancement with a wire. You pull back the wire too much, you can't get in. So the left-sided lines are a bit challenging to exchange. Right-sided are always better. Femorals, you know, try not to exchange those. You want to get those out, you know, sooner the better, because that has risk for complications much higher than IJ sites. These are proven to be the least amount of complications when using ultrasound in the right IJ, and the less infections for sure in terms of site selection for a Central Line placement. Yeah.
I have 2 things. Number 1, do you want to have them see my jugular?
Sure.
And then number 2, if the patient's coagulopathic, like their INR is really high, would you want us to like transfuse them, give them platelets, give them?
So that's always at the
as a
discretion of
feeder?
the doc, and I think
Okay.
you have to have a conversation with the doc who's going to place a line.
Okay.
Like
So
I'm-
if the
I'm-
INR is greater than 3, let's say, would you want us to say, hey, do you want us to give some FFP before you do
And
this?
it depends on the situation. So if somebody needs a line and they're crashing now, the line's going in whether the INR is 2, 3, 4, or 5,
Gotcha.
right?
Okay. Fair
And
enough.
then you deal with the consequences in terms of bleeding, transfusion afterwards. If you have time and you have the luxury of having some time, ideally having the INR around 2 or less than 2 would be ideal.
Sure.
Especially if you're going to go with an HD catheter that has a much bigger dilator
Sure.
and a bigger French. You want that INR as low as you can get it, maybe even giving some FFP prior to the procedure if you have access. If you don't have access, you're kind of stuck.
Okay.
Have I done it? Yes. I mean, I'm sure you've had emergent situations where they're coagulopathic and you have to put a line or an HD catheter.
Absolutely.
And it is what it is. But ideally, yes. And you can get bleeding from site. Sometimes you'll see us, and those patients, they'll bleed right from the site of insertion or even from the sutures.
Sure.
Okay. And they'll ooze. Sometimes you can get Surgicel, wrap it around
Absolutely.
the line. We can have some of that.
Sure.
Or the foam as well helps too. But the Surgicel is nice because you can kind of cut it and wrap it around, and it'll just clot around the line as well. What else? A lot of questions about setup, like we talked about from the beginning, in terms from your all standpoint, like in terms of prepping the line, getting the wires out of the way, getting the patient to lay flat, getting them to lay back, talking to them, sort of saying, hey, this is what's expected, this is what's going to happen, and prepping them, etc. She's being a really good patient right now, so she's staying still. So Chuck, you want to come up here and I can show?
Absolutely.
And one thing I want to point out, guys, is I did print the Mosby's on this. It's a very extensive, overview, patient education, risk benefits, supplies, post. And one thing I want to ask Dr. Alvarez is cleanup time.
Okay, yeah.
Yeah, well, tell me what you take and dump and what I need to touch.
So I do not want any of you all touching my sharps.
Cut the video.
Yes.
My sharps are my sharps.
We're at 35
My
minutes.
sharps are the sharps.
We cut it.
They should not be asking you to take their